This is a chest radiograph of a middle-aged woman presenting with progressive shortness of breath and worsening cough. The frontal radiograph shows subtle increased opacity in the region of the left upper lobe with evidence of volume loss on the left, manifested by mild elevation of the left hemidiaphragm and a possible juxtaphrenic peak. There is also increased lucency around the aortic arch, known as the Luftsickle sign, which represents interposed hyperexpanded left lower lobe between the collapsed upper lobe and the aortic arch. On the lateral projection, there is an anteriorly located opacity overlying the ascending aorta, with relative hyperlucency posteriorly in the retrosternal space, representing hyperexpansion of the left lower lobe and the contralateral right lung. CT confirms the presence of a left upper lobe collapse caused by an endobronchial mass obstructing the upper lobe bronchus, consistent with a non-small cell lung carcinoma, specifically squamous cell carcinoma. Left upper lobe collapse is often one of the most difficult lobar collapses to recognize on chest radiography because the changes can be subtle and the opacity can blend with mediastinal and hilar structures. The key findings include a vague, ill-defined opacity in the left upper zone, volume loss, elevation of the left hilum, and the Luftsickle sign, which is highly suggestive of this diagnosis. The Luftsickle sign occurs because the left lower lobe hyperexpands posteriorly and curls around the medial margin of the aortic arch, creating a crescent of lucency adjacent to the aortic knob. On the lateral radiograph, the collapsed upper lobe produces an anteriorly located opacity bordered posteriorly by the oblique fissure and anteriorly by the hyperinflated right upper lobe. The lower lobe fills the space behind the collapsed segment, producing the characteristic appearance of increased retrosternal lucency and the apparent prominence of the oblique fissure. The main cause of left upper lobe collapse in adults is endobronchial obstruction, most commonly due to malignancy. Though mucus plugging can occasionally cause this pattern, in the absence of another clear explanation, malignancy must always be presumed until proven otherwise. In this case, bronchoscopy following CT confirmed a centrally obstructing squamous cell carcinoma. Management depends on the underlying cause. For malignant obstruction, treatment involves bronchoscopic biopsy to establish histologic diagnosis and subsequent oncologic management. For non-malignant causes, pulmonary toilet and bronchoscopy to remove mucus or foreign material are appropriate. Regardless, left upper lobe collapse should always prompt CT and bronchoscopy to exclude a central obstructing lesion. In summary, this case demonstrates left upper lobe collapse due to a central squamous cell carcinoma, showing the classic Luftsickle sign, left volume loss, and anterior upper lobe opacity, key high-yield findings that must prompt immediate further evaluation for an endobronchial mass.